shift will be from anti-VEGF to another anti-VEGF before we are going for the steroid, or we can move directly to the steroid, or there will be no rule for steroids anymore?
That's a really good point. I think it depends on the lens status, I'll be honest with you. If they're phakic and their diabetic macular edema doesn't respond to a first-line anti-VEGF agent, I would switch to a newer anti-VEGF agent, but I would only give a couple of injections, see that patient very closely, because what I don't want to do is for the irreversible retinal damage to kick in, because if they're not responding to that newer anti-VEGF, I want to switch to steroid at the earliest convenience. If they're a pseudophakic patient, honestly, what is the risk? What are you going to do to the eye? There is a 1 in 3 chance that you will have to give them ocular hypertensive drops. But we know with Ozurdex, the vast majority of patients, their ocular hypertension rise is manageable. And if it was a pseudophakic patient, I'd just make the switch directly. I wouldn't try a second line, because I think the benefit risk is favorable to giving a steroid in that case.
Yeah, I think I agree, because we need to remember, simply those who will not respond to anti-VEGF, most probably will not respond for anti-VEGF. Except, of course, if we say faricimab is working in 2 pathways, Ang2 and the anti-VEGF pathway. However, I think the steroids will remain there, because big part of the pathophysiology of the disease is the inflammation, and this is why we need to consider
but
early switching.
Some patients may not be able to tolerate the frequency of treatment that they need with VEGF, anti-VEGF.
Yeah.
So actually, steroids are still the steroids that we have are still the long-acting agents.
Yeah, definitely, without that. But you can argue about this, because faricimab, for example, in 50% of patients, they will stay on 4 months, and 70% will stay in 3 months.
That's a good point.
But of course, the main drive, I think, in my opinion, the inflammation here. The other thing is, did you give Ozurdex for glaucoma patients or not?
It's a really good question. So I have given Ozurdex in glaucoma patients, but I would always give it as a second-line agent. So so you have a glaucoma patient. I'm treating their diabetic macular edema initially with anti-VEGF, but if I'm not getting vision improvement or anatomical improvement, at the end of the day, you can't. Once the retina is damaged, once macular ischemia or macular degeneration kicks in, you can't rescue that eye. You can't rescue that central vision. And so I could justify the risk from an Ozurdex implant in a glaucoma eye, because the vast majority, the pressure response will be manageable with drops. But on the odd occasion where I was worried that their glaucoma was brittle, I would have a conversation with my glaucoma colleague, and they would just say, look, you do what you need to do to manage the maculopathy, manage the retinopathy, I'll manage the pressure. And I can really say hand and heart, in the 13 years as a consultant, I can only think of one Ozurdex patient, and maybe only one Iluvium patient needing filtrating surgery. So there was going to be a lot of patients who would not benefit from steroid because I was worried about this very tiny risk.
Yeah.
At the end of the day, our job is to save retina, is to improve vision, because it makes a difference to that patient's quality of life.
I'll just echo what Fahd said just now, because simply I used it for many glaucoma patients, to be honest. I'm a retina surgeon and I'm a retina consultant as well, but that's what exactly meant to be. Yes, you can use it in glaucoma patients, because simply not every single one will be a steroid responder. That's the first of all. Second, I think the guidelines started to say if he is in 1 drop or 2 drops of glaucoma, you can still use it, because you can still have the 3rd-line treatment for glaucoma patients. I'll not consider it in someone who is already on 3 glaucoma medication, except if I have to. As Fahd said, we need always to remember that damage to the retina is irreversible. So whatever happening from the edema, if the patient is not responding, cannot return it back. But anything else with the steroids, including the pressure or the cataract, I can treat it. Okay, that's what we have to remember. Actually, I think unfortunately, we reached to the end of our talk, but if I'm going to summarize in 3 or 4 words what Fahad said, I'll just say early switch is a key because simply people keep injecting, and by the time we switch, we lose vision. Second, steroids can be used as a first line of treatment. Third, even with the new players coming to the market, I think the steroids will always have a role because simply it is part of the disease is inflammation. Thank you very much for listening.
Thank you, Ibrahim.
احمد شو رايك؟ انا والله ماني خاطر اتكلم احكي.
لا لا لا
احكي يا باشا.
لا 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 احكي.
Hello, hello. Assalamu alaikum. Good evening, dear colleagues. We'll go to next sessions. Dr. Ayman, Dr. Fahad, we will go to next session, please. Thank you very much. Next session, it will be a medical retina session. It will be a debate. And I have with me Dr. Nazim Al-Hussein and Dr. Ahmed Al-Khasham, Dr. Muhammad Aoudallah to moderate this session. So this session, it will be a very strong, so you have to concentrate and see who's going to beat other ones. So the first one, the first presentation, Dr. Mandib, and he's going to talk about brolucizumab. Then we'll have Dr. Prasan Rao, he will talk about faricizumab. So we want to see who is going to win in this debate. So Dr. Mandib, you are there? Okay. So everyone having 5 minutes presentation? No, you can see them.
So, ladies and gentlemen, a very good evening to all of you. From the onset, I would like to thank the Meom Society and the gentleman on the dais. Thank you very much for giving us platform to share our thoughts, experiences, etc. My thoughts on this particular topic is actually pretty divisive. I think it's unfair if I'm going to put both the molecules head to head. Both are fantastic molecules. And the big thing is there is no head-to-head study as of now comparing both of them, putting them in the same tray. So we don't know which one is superior and which one is not directly. So what I'm going to do is take an indirect route, basically taking some snapshots from the previous studies which allowed these particular molecules to come to our shelves. That is comparing them with the previous molecule, Eylea or aflibercept. So what do you expect from your anti-VEGF? What is the ideal anti-VEGF? It should be a good molecule with good pharmacodynamics. It should give you a good visual acuity gain. And that should be predictable and sustainable. We all want to look at something which gives us drying capabilities, and that too with few injections. And of course, we want it to be safe. So if you look at the brolucizumab as a molecule, it's a very dynamic molecule. It has two ends. One is a hard end and the soft end. The softer end is actually a V-chain immunoglobulin, which has got a molecular weight of 26 kilodalton, and that gives a dynamicity to the whole molecule, allowing it to have good perfusion as deep as choroid and RPE layers. One interesting fact about the molecule is its serum concentration has been proven to be less than 6,000 times of that in vitreous cavity. So if you look into this particular parameter, that of aflibercept was 950 times. So we used to talk about all the systemic side effects and all. Probably we have a more safer molecule in that respect. Visual gain has been repeatedly proven by different studies. This is a snapshot from Kite and Crystal, Kingfisher. Everyone has shown that basically this molecule is non-inferior to aflibercept. And this is a snapshot from Kingfisher study. Again, it proved that this particular molecule is non-inferior to aflibercept. These responses have been predictable and sustainable. And if you look into this particular snapshot from Kite and Crystal trial again, you will see that 87% of patients who were injected with 6 milligrams of brolucizumab could actually were put on quarterly injections after a loading dose after the first DA approval. So you have a kind of predictability factor when it comes to these injections. Similarly, brolucizumab 6 milligram when injected after the initial loading dose, if the DA approval was there and DA was positive, that is, they did not show an active activity at the macula, 70% of these patients could be directly on either 3 monthly or 4 monthly interval injections at the end of 2 years, that is 100 weeks. That is what I really need from my anti-VEGF that I use for my patients. I need it to have a good drying capability. I see this as, the improvement in the visual acuity is a byproduct of drying of the macula. It has been repeatedly proven in different studies that brolucizumab in comparison with aflibercept has significantly higher capability to dry macula. This is again a snapshot from Kingfisher trial. Not only at the end of the study, but starting from the first injection to the last follow-up, you had better responses and cumulative responses. So the more number of patients who could have dry macula kept adding till the end of the study. This particular slide, again for Crystal and Kite, shows us that all these clinical and subclinical achievements could be done with fewer number of injections. So if you look at this particular slide, at the end of 100 weeks in Kite and Crystal, the number of injections used, brolucizumab used in comparison with aflibercept were 11:15 in favor of brolucizumab and 10:15 in favor of brolucizumab. So obviously good response with lesser number of injections. There's a lot of talk about safety of brolucizumab since this molecule has been put in place and it's on our shelves. So if you look here, I would like to concentrate on Kite trial. The Kite trial had the cohort which resembles genetically the kind of patients we treat, that is Asians. In Kite trial, both the arms basically had comparable IOIs or intraocular inflammations. If you look into the Crystal trial, there were 3 such patients who had vascular occlusions, but all the 3 were actually attributed to the disease process, but not to the drug interactions. Similar profiles were also seen in Kingfisher trial. Last but not the least, brolucizumab is a molecule which is undergoing a